Tracy, just let me know when you want me to start.
Yes, we can start right now.
Okay, wonderful. All right. Good morning, good afternoon, and good evening to everybody who's present here on this webinar. I would like to thank Easy Search Medical for actually organizing this webinar today. Today it'll be an APAC and an EU thoracic surgery webinar. And we have today, well, I'm the host. I'm Dr. Harish Mitran. I'm thoracic surgeon based in Singapore. And today we have three wonderful speakers with us. We have Dr. Nara Simon Satyamurthy, and Dr. Nara currently is a consultant thoracic and general surgeon at Hospital Kuala Lumpur in Malaysia. He is also the head of thoracic services in Malaysia right now. His main primary interests are in non-intubated uniportal VAT surgery, uniportal thoracic surgery, chest wall resection and reconstruction surgery, as well as non-intubated tracheal resection surgery. Dr. Nara today will deliver a compelling talk on uniportal approaches to 4L station lymph node. And this topic is of great interest and relevance because, as we know, to dissect the 4L lymph node from the left side is actually quite a tough procedure to do. Next, we'll have Dr. Wojt Molgarzata, and she's been a thoracic surgeon since 2014, and she completed her thoracic fellowship in Papworth Hospital in 2015. She completed actually her doctorate and her scientific doctorate in 2016 after that, and she's currently right now a dedicated practitioner at the Department of Thoracic Surgery and Transplantation at Pomeranian Medical University in Poland. And today, Dr. Malgorzata will actually be talking on MIS approaches to esophageal resection and how to deal with complications. And the third speaker today is Dr. Gerard Francis Lopez. Dr. Gerard currently is the head of department of cardiothoracic surgery in Hospital Raja Perempuan Zainab, Kota Baru in Malaysia. And he's also the head of cardiothoracic services for the state of Kelantan and Terengganu in Malaysia. And that's a very large area in Malaysia. It covers a large population, and he's got extensive knowledge in managing cardiothoracic patients there. Today, Dr. Lopez will speak on tips and tricks for chest wall reconstruction. And I'll conclude the day today with a slightly different topic, which will be on why we want to move to robotic thoracic surgery. And then we'll conclude our topics, our webinar for today. So to kick it all off, we'll start with Dr. Nara. Dr. Nara, you have the floor.
Thanks, Harish. It's been a pleasure to be back in the webinar. Since the COVID days, most of the time we've been having these webinars, and now we're back to face-to-face. It's nice to look at the computer screen and present. Thanks to the organizing committees for inviting me to discuss a little bit on one of my favorite topics, which is 4L dissection, uniportal VATS approach. And let's get on. As for disclosure, I'm receiving an honorarium for this talk, and videos are consented for academic presentations. So why is 4L very interesting subject to discuss, especially when it comes to thoracic uniportal VATS surgery in lung cancer? So if you look at most of the major textbooks that we have, for example, Shields, the discussion on lymph nodes, especially in the left thoracic compartment, is limited to the station 5, 6, 7, 9, 8, and they don't discuss on 4L. And if you look at other books like Atlas of Endoscopic Major Pulmonary Resections, somehow the 4L is left out from the discussion. They go about station 11, 12, 13, 10, 9 and 8, 7, 5 and 6, 7, 4R, 2R, and 3A. So 4L is not discussed as well. If you look at the latest published books, Video Atlas of VATS Pulmonary Sublobar Resection, the 4L is not discussed as well when it goes to the left lymphadenectomy operative steps, is level 5 and 6, 7, 8, 9, 10, 11, 12. So, and finally, Atlas of Uniportal Video Assist Thoracic Surgery, Diego mentioned a paragraph about 4L in the whole book. He said that it is difficult to dissect lymph nodes at level 4L, and with single port view, you can perform a left paratracheal lymphadenectomy under the aortic arch. It is important in this step to avoid injuring the recurrent nerve, and usually have to push the aortic arch with a harmonic scalpel and grasper to complete the dissection. So this is all that is mentioned about 4L dissection in his book. So why is it so controversial? Why is it not discussed in all these major books? Number one, as we know, it's difficult to access. If you can appreciate the diagram here, which I adapted from one of the journals, written by Christopher Ferolius in routine dissection of lymph node station 4L clinically significant. So if you can see, this is the trachea, the left main bronchus, the pulmonary artery, the arch of aorta runs there. Then you have the ligamentum arteriosum connecting the arch to the pulmonary artery. And then behind here is the esophagus. And then beneath in this window is where you get that 4L lymph nodes. And it goes posterior to the arch of aorta. So that's the reason why it's difficult. And one more reason is that along here, the recurrent laryngeal nerves will hook around the ligamentum arteriosum and follow the course of the trachea up to the neck. So because of this difficulty to access, many people don't do 4L dissection. And along with this narrow window of dissection comes high complications, because it's easy to injure the recurrent nerve. It's easy to injure the pulmonary artery because you need to retract it inferiorly, the arch of aorta, especially in elderly patients. If it's calcified, it can cause dissection of the aorta if it's not carefully handled. You may also injure the esophagus if you can't estimate the depth of dissection posteriorly. So all these complications can be quite grave if it happens. And so naturally, people don't want these complications and they avoid. And there's also another argument is that the 4L lymph node status should have been diagnosed preoperatively by PET-CT, EBUS, mediastinoscopy, and so on. And with these diagnoses, then we should have treated the 4L. So that means a neoadjuvant chemotherapy should have been advocated if 4L is found to be positive, or the surgery maybe should not even have been conducted. But that is controversial to discuss because nowadays we have this upfront surgery for single station N2 and so on. And based on the guidelines, there are varying recommendations. Like British Thoracic Surgery guidelines, the recommendation is you need to take out 6 lymph node station, 3 mediastinal and 3 hilar, but 4L is not specified in the guideline. ESTS and NCCN actually emphasize that 4L evaluation is needed on left-sided lung cancers. American College of Surgeons Oncology Group, the Z0030 trial, mentioned that comprehensive lymph node evaluation is needed for left-sided lung cancers, but they did not mention about 4L in the guideline specifics. Bronchogenic Carcinoma Cooperation Group of the Spanish Society of Pneumology and Chest Surgery emphasized that 3 stations should be dissected in left-sided tumors, but not 4L. Zurich Medical University emphasized that 4L, 5, and 6 need to be removed. Do we have Asian data? Well, yes, we actually do. Wang and colleagues have looked into clinical significance of 4L lymph node dissection in left lung cancer. So now we are trying to emphasize why is 4L dissection important. Wang looked at 657 patients, and he divided about 139 of them had 4L lymph node dissection, and another 518 did not have 4L lymph node dissection, and they compared between these two groups. And what he found, interestingly, in his analysis is that the metastasis, if you look at the bar chart here, the metastasis with the 4L and 5 lymph node is almost 21% as compared to the other stations in the mediastinum, like station 7, it's only 14%, station 6 is 15, station 8 is 13, 9 is even lesser. So we are actually having quite a significant number of metastases in 4L lymph node that we are missing if we don't dissect and remove these lymph nodes, especially in left upper lobe lung malignancy. So, and what he found that he concluded from his study, station 4L lymph node involvement is not rare in left lung cancer, and dissection of 4L lymph node seems to be associated with more favorable prognosis as compared with those who did not undergo this dissection. So if you look at the overall survival and disease-free survival, there's a significant difference between the group of those who underwent 4L lymph node dissection versus the group that did not go for 4L lymph node dissection. That is the first paper. The second paper published in 2023 by Shen and colleagues on the clinical pathological and survival outcomes of 4L lymph node dissection in left lung adeno CA versus squamous cell CA. And what they found is that the incidence rate of station 4L metastasis was 17% in their group, and it's more common among the adenocarcinoma group as compared to squamous cell carcinoma. And of course, in conclusion, the station 4L metastasis is not rare. Patients with adenocarcinoma have greater predilection for station 4L metastasis and may benefit more from performing 4L lymph node dissection. So these are the two main papers I found in Asia. I haven't gone into the Japanese group. I'm sure there's some data there. I have to look into that, and maybe some of y'all can look into it as well. So having said all that, now let's look at the technicality of the surgery. So I had the privilege to perform a 4L dissection in one of my patients recently. And this patient, the left upper lobe is still intact in the video. So I had to retract the left upper lobe inferiorly. And then once the space is created, the dissection to the AP window started with energy device. I like to use Easy US NAZ device because there's less smoke and it's easy to dissect. So I've been using this for a while now. So the whole surgery is performed by only the suction and the energy device with some dissectors assistance. So the dissection first started by opening up the pleural space, careful not injuring the aorta and the pulmonary artery that is causing posterior to the pleural space. And the dissection is done carefully, making sure the active blade of the energy device is always away from the vital structures. And before reintroducing the dissector, we must make sure the heat in the active blades is dissipated in any other non-important structures, so that the remnant heat in the active blade will not cause any injury, especially to the nerves. So normally I like to open up the pleura all the way up to the exposing the vagus nerve, trying not to injure it. And once we've opened up the pleura nicely, and we can appreciate the structures in the AP window, and the dissection into the depths of the AP window can be started. So it's always gentle dissection. Try not to cause any bleeding, clear off the fascias. And then once all the fascia is cleared and the vagus nerve is nicely displayed, there will be nodes on the recurrent laryngeal nerve just adjacent to the vagus. So this has to be dissected carefully and gently. Try not to use energy device when you're trying to separate the node from the recurrent laryngeal nerve. Once you've got the planes created, and then the energy device can be used, so that we don't inadvertently injure the recurrent laryngeal nerve. So now I've got the plane, I know exactly where to apply the energy device, and the active plate must always be in the view so that it's not going to cause any damage to unwanted structures. So you can see the recurrent laryngeal nerve is tented by the lymph node, but I'm not holding the nerve, I'm just holding the lymph node. So once the dissection is done, we can appreciate the structures clearer now. And from here, you can see that's a vagus nerve. This is the recurrent laryngeal nerve, and this is the ligamentum arteriosum. And now I'm dissecting into the 4L region, trying to expose the white of the trachea. And here you can appreciate the nodes. So this is the distal trachea, and here's the pulmonary artery, the arch of aorta. So this is the 4L region. Okay, so another caution here is that when we retract the PA downwards, you have to be gentle, not to apply excessive pressure. And it's better if the lung is attached still, because we can use the lung to retract the PA down. If you have done your left upper lobectomy, there will be stapler lines on the apical vessels. And you have to be careful not to shear those stapler lines or get hooked in the head of the suction, and that can cause bleeding if not careful. So at this point, the dissection is done in the area of the 4L, and the lymph nodes are dissected carefully and separated from the lateral tracheal wall. So it's done very gently. Take your time, and there's no rush. If you can't visualize the active blade in the plane of dissection, you need to use a dissector or forceps to hold the lymph node out into the view, and then perform the then apply the energy device to dissect the lymph node away. So that's pretty much the dissection of the lymph node on the 4L. And here we can again appreciate the vagus nerve. That's your recurrent laryngeal nerve I'm pointing. Here's the ligamentum arteriosum. The nerve is hooking around the ligamentum arteriosum. Pulmonary artery is here. Trachea, arch of aorta, and down here will be the left main bronchus. Well, that's pretty much about the dissection of 4L lymph node using a uniportal technique approach, and it could be done safely, and I think it should be performed routinely in all patients with left upper lobe adenocarcinoma. With that, thank you, and I'll be happy to answer any questions.
Great. Nara, maybe we'll keep the questions till the end. So let's move on with the next topic.
Sure. Thanks.
So next we have Dr. Mal Gorzata, who'll present to us with a minimally invasive esophageal resection, her own experience, and how to deal with complications. The floor is yours.
Tak. Nie, to zamknijmy. Tutaj i tutaj Okay.
Good afternoon, everyone. It is my great honor to be invited to this interesting meeting. My name is Małgorzata Wojtyś. I am thoracic and transplant surgeon, working in thoracic surgery and transplant department in Pomeranian Medical University in Szczecin, Poland. And in our department, we do lung cancer surgery, esophageal surgery, and lung transplant procedures. Each year, we perform about 800 procedures. And in this amount, there is about 220 resection due to the primary lung cancer. We had a great opportunity to participate in the previous lecture about 4L lymphadenectomy. And now my topic is about the complications in minimally invasive esophagectomy. The head of my department is Docent Janusz Wójcik, and he is also the head of the minimally invasive esophagectomy program. In our daily practice, we faced with the complications working as the surgeon. So it is very important to know how to treat those complications. So the the complications, surgical complication, we can define as every unintended and undesirable event which occurs in the postoperative period. And surgical complications can be divided into local or general, and also into the early and late. The local surgical complications could be associated with surgical wound, and the general are associated with different organ and symptoms. The early complications are dependent on the time of the onset. The early one are less than 30 days, appear less than 30 days after the procedure, and the late appears later than 30 days after the surgery. There is a Clavien-Dindo grade system, and there is a classification used regardless of the type of surgery. We can also use this classification when we talk about complications in minimal invasive esophagectomy. And this classification is based on the required intervention to treat specific complication and patient conditions. And for example, grade 3, according to Clavien-Dindo system, is the complication which required surgical, endoscopic, or radiological intervention. And for example, in grade 3 could be bronchopleural fistulas after thoracic surgery required closure. The complications we can divide into medical and surgical, which we can face after the minimally invasive esophagectomy. And the medical could be major and minor, and as well surgical could be major and minor. So the medical major could be respiratory complications or cardiac complications. We can notice after the procedures as a respiratory complication, aspiration pneumonia, bronchopneumonia, respiratory failure, or acute respiratory distress syndrome. And the cardiac complications could be myocardial infarction, unstable angina, or thromboembolism. The minor could be different kind of arrhythmias, psychiatric problems, urinary tract infection, or for example, infective diarrhea. The surgical could be major and minor, as I mentioned before, and the major one could be very, very dangerous, very serious anastomotic leaks, conduit necrosis, high leak, recurrent laryngeal nerve palsy, could be bleeding during the surgery. Could be gastrobronchial fistula, injury of tracheobronchial tree, tumor rupture and contamination of the operating field, or strictures. The minor one could be wound infection, could be effusion, pneumothorax, or delayed emptying or collection of the intra-abdomen fluid. During the surgery, we can face the intraoperative complications, which could be bleeding, arrhythmia, hypotension, or tracheobronchial tree injury. The early one could be pulmonary complications. The most common one could be pneumonia, atelectasis, acute respiratory distress syndrome, could be fistula of the esophageal anastomosis, hyalothorax, or diaphragmatic hernia. And the late could be stenosis of the gastroesophageal anastomosis, the dumping syndrome, diarrhea, or the very late could be the recurrence of neoplasm. One of the serious complications is the anastomotic leakage. The incidence in minimally invasive esophagectomy, it can happen between 0 to 12% of the cases, and it is one of the most common and serious complication after the esophageal resection, and it could be divided into type from 1 type to type 3. Type 1 could be dealt with conservative treatment. Type 2 needs interventional treatment, for example, imaging, guiding drainage or stents, and type 3 needs surgical treatment. And here I have the CT from my department with anastomotic leakage after minimally invasive esophagectomy. You can see the leakage here. And there is one more case with the same complications after the esophagectomy. You can see the leakage. The contrast is going outside. So other very serious complications could be conduit necrosis, and it could be also divided with to type from 1 to 3. The type 1 is focal conduit necrosis, and type 3 is extensive conduit necrosis, and there is different type of treatment depends on the severity of the problem of the necrosis, and for diagnosis we use endoscopic tests, and we have different of kind of treatment. Could be the most severe needs surgical treatment with conduit diversion. And here we can see a few images of the CT with conduit necrosis. After the minimally invasive esophagectomy. The other problems after minimally invasive esophagectomy, which we can face, could be recurring laryngeal nerve paralysis, and it could be also divided from type 1A to type 3B, depends on the severity of the problems. Sometimes after the minimally invasive esophagectomy, we can observe a high leakage, and it could be treated conservatively, or sometimes it will need surgical intervention, depends on the severity of the high leakage, and so we can divide it from type 1A to type 3B. And the most severe is type 3B, when there is the high leakage is more than 1 liter per day, and it will need surgical or non-surgical intervention. There is a lot of papers devoted to complications in minimally invasive esophagectomy, and they compare open versus minimally invasive approach, hybrid minimally invasive approach, and also open versus robotic esophagectomy. And there is one paper from 2019 by Mariette, and these papers compare open versus hybrid minimally invasive approach in esophagectomy, and the papers shows that minimally invasive surgery was associated with about 77% lower risk of major intraoperative and postoperative complication within 30 days than open surgery, and the risk of major pulmonary complication was 50% lower in the hybrid procedure group than in the open procedure group. There is other paper, the paper also, there is a paper which compare open versus the hybrid minimally invasive approach, and in the study there is a better survival observed in minimally invasive group, but the statistical significance was not met. There is a paper by Chen from 2021, and we can, based on this paper, we can find out that minimally invasive esophagectomy compared to open esophagectomy, there is a shorter operative time, there is a less blood loss, less frequent anastomotic leak, but there is no statistical difference between rates of acute respiratory distress syndrome, pneumonia, hylothorax, or arrhythmia. And there's patients with neoadjuvant chemoradiation in minimally invasive group showed statistically better overall survivor compared to open surgery. And there is a paper from 2022 which shows that that compare total versus hybrid minimally invasive approach. And in total minimally invasive approach, there is a less blood loss, longer, although there's longer operative time, but there is a less frequent pneumonia and pleural effusions. There are also papers about robotic surgery in esophagectomy, and there is a paper from 2019 which compare open versus robotic assisted esophagectomy, and it shows that robotic surgery was associated with decreased frequency of clavien-Dindo 2 and more than 2 grade complications, and reduced rate of pulmonary and cardiac complications. The paper from 2022 compares minimally invasive approach versus hybrid or total versus robotic assisted surgery, and it shows that overall complications rate between robotic and VATS minimally invasive surgery were statistically similar, and high leak development were more often in robotic group, and it was correlated with surgeon experience and MAC-own technique. In our department, we do minimally invasive surgery, and the program has started in 2005. And the first patient was operated with minimally invasive technique with free field resection. We can see the patient, and the patient was operated due to the squamous cell carcinoma, early stage T1 and 0 M0 first stage, and the patient had great survival. The patient survived for the 10 years. On the X-ray, we can see the contrast, the esophagus chest view with the contrast, and it looks great, it looks fine. No stenosis, no high leak, no leakage. Unfortunately, the patient had the second cancer, and on this X-ray from 2015, so it is after 10 years after the esophagectomy, minimally invasive esophagectomy, we can see the X-ray after pneumonectomy. The patient developed the second cancer. He had lung cancer, and he had the surgery due to the lung cancer, the pneumonectomy, and unfortunately, this was the reason for his death due to the lung cancer, but the minimally invasive esophagectomy was really, really good in this case, and the survival was great. So in our department, among 344 cases of esophageal resection, about 20%, which is 62 cases, were performed using minimally invasive techniques. And in this group, we are having 20 cases of hybrid esophagectomy, 1 case of minimally invasive transhiatal esophagectomy, 4 cases of minimally invasive laparoscopic cardiectomy, 17 cases minimally invasive two-field esophagectomy, and 20 cases of minimally invasive three-field esophagectomy. When I compare the demographic data of our patients, about 60% were the patient between 51 and 70 years old. we have a group of the patient which were 70 years old and older, and it is almost 26% of the patients. The most of the patients were men, about 80% of the cases. And when I look for histopathology, I found out that almost 94% of the patients had esophagectomy due to the malignant reason, and only 6.5% was due to benign problems. And in the group of malignant cases, the most often was squamous cell carcinoma, 54% of the cases, and adenocarcinoma was less often. It was about 41%. There was 5% of other malignancy, like carcinoma malady differentiation and others. I also compare all the approaches we used to do minimally invasive esophagectomy and what kind of anastomosis we've done. And when I go through all the abdominal approaches, I found out that we've done minimally invasive approach 72%. Sometimes we need to do the open approach during the abdominal part of the surgery. It was 27% of the cases. And when I check the thoracic approach, I noticed that we've done it minimally as a minimally invasive procedure, almost 90% of the cases, and open more than 10%. Sometimes we do cervical approach, not always. Sometimes we only do two-field esophagectomy, but sometimes as a three-field esophagectomy. So about 60 cases has been done with cervical approach, and so there's more than no cervical approach cases. And of course, after the procedures, we observed complications. There were surgical, medical complications. About 30% of the cases had no complications at all, but there were surgical complications about less than 50%, and some of them had medical complications, which were about 34% of the complications. And between the complications, the most common was pleural fluid. It was easy to deal. We do the thoracocentesis, or sometimes when the pleural fluid recur, we need to do the chest drain insertion. Some of the patient had anastomotic leakage. It was about 50% of the patients. About 10% had conduit necrosis. Some of them, about 8%, had impaired wound healing. Sometimes happened stenosis of the anastomosis, which were present in 6.5% of the cases. Pyloric stenosis was present also in the same amount as the stenosis of the anastomosis, which is 6.5% of the cases. About 5% as the complications were pneumonia, the same amount intraoperative bleeding. 3.2% were atrial fibrillation. There were present also high leakage, tracheobronchial fistulas, but it were very rare. Sometimes delirium after the surgery, bleeding from digestive tract. There was one case with acute lower limb ischemia, one case with diaphragmatic hernia, one case with urosepsis. Unfortunately, some of the patients died after the surgery or late after the surgery due to different complications, sometimes medical, sometimes surgical complications. Some of the patients need blood transfusion. More than 50% didn't need any blood transfusion. So how did we treat the complications? As I mentioned before, 40% had no complications at all. And those who had complications, in the group of complications, we use conservative treatment in about 8% of the cases, but in the rest we need invasive treatment. Some of the complications were managed endoscopically, like when there was a stenosis of in the anastomosis, then we can do the dilation. We can insert the stent in case of the leakage, or sometimes when there is a problem with the healing with the leakage, we can use the endovac as a treatment. Some of the patients needed minor procedures under local anesthesia. It was a little bit more than 20% of the cases. So when there was a pleural effusion, for example, the patients needed drainage insertion or thoracocentesis. Less than 30% of the cases needed procedures under general anesthesia. For example, wound revision, surgical treatment, resuture, reanastomosis, or sometimes even salivary gland fistulas. In case of intraoperative bleeding, of course, the action was necessary to stop the bleeding. So those are the cases from the group which needed procedures under general anesthesia. And as I mentioned before, there was one case with acute limb ischemia. So this is the patient. The patient had minimally invasive esophagectomy. It was done by VATS, laparoscopy, and cervicotomy. So it was free-field esophagectomy, minimally invasive. And the patient was 63 years old. The surgery was due to the squamous cell cancer, esophageal cancer. And it was early stage, T18 and 0M0. 24 lymph nodes has been taken. The cancer was present in 1/3 upper part of the esophagus, but unfortunately, in the first postoperative day, acute limb ischemia happened, and the patient, it was so severe, so the patient needed amputation. So here you can see more images of anastomotic leakage, which were present after the esophageal minimally invasive esophagectomy. And there is the last one is after the treatment. So it was successful. The treatment was successful. There is one more CT with anastomotic leakage present after the esophagectomy. And there is few images of the stenosis of anastomosis present. There is the CT. There is a CT of the anastomosis, stenosis of the anastomosis, and there are X-ray. We can see there is the lumen is stenotic, really tiny. And of course, one of the complications, very severe, is the conduit necrosis, which is visible on the X-ray. There was a pyloric stenosis, which is visible on the X-rays. And we had one case of huge diaphragmatic hernia. The patient needed surgery because it was really huge. You can see it on the CT. And after the surgery, the patient was well, so it was good post-op course. And on this X-ray, we can see the stents. Sometimes when there is the leakage, the patients needed the stent. So on this X-ray, the esophageal stent is visible. And in case of pneumonia, of course, there is a treatment, antibiotics, all the which according to the hospital microbiology recommendation. And when there is few pictures with pleural fluid, which were managed with the chest drain insertion or sometimes with thoracocentesis and were successfully treated. We must know that open esophagectomy is associated with significant risk of complications, and it is almost 64%. So it's really high risk of complications. And minimally invasive technique offer shortness hospital stay, operative time, less blood loss, and decreased rates of complications as compared to open surgery. But we need further studies to evaluate differences in complication rates between robotic assisted and minimally invasive esophagectomy. And when we talk about the complication, we must know that surgeon experience and technique of surgery are potential factors that contribute to different rates of complications. Thank you very much.
Oh, thank you very much,
And
Dr. Wojciech, for your...
on the last picture, there is Professor Wójcik with the patient, and he's the head of the esophageal cancer resection program, minimally invasive program.
Thank you very much, Dr. Wojciech. Really, really good insight to esophageal surgery in your center. Really appreciate this talk. We'll keep the questions to the end. Our next presenter will be Dr. Gerald Lopez, and he'll be presenting on chest wall resection and reconstruction. The floor is yours, Dr. Lopez.
All right. Thank you, Haris. Good day to everybody. I hope you all can see my slide. So just sit back, relax. I'll just show you some tips and tricks, pictures and videos. All right.
Great. Dr. Gerald, I haven't got your slides up yet. Okay, can you see it now? Yes, now we can. Thank you.
Sorry, thank you about that. Okay, so this will basically be the outline. I'll talk a little bit of the principles, a bit of the imaging, and a few case presentations we can discuss. So a disclaimer is I am a cardiothoracic surgeon. I actively manage chest wall disease. It's something I'm very interested in. I'm also receiving an honorarium from Easy Search, and all your pictures and videos you see actually be taken with consent of the patient. So these are the principles of chest wall surgery. You need to resect. After you resect, you need to reconstruct. After you reconstruct, you need to make sure that from your reconstruction, you have preservation of function. So the question is, must you fix all? So this is a patient, if you look at the date, it's very recent, it's just last month. Very bad chest wall injury, multiple scale segments on the left chest. Every thoracic surgeon will jump and say, yes, we need to fix this, we need to fix it as soon as possible. And yes, there is survival benefit when you fix and then you reduce complications. But also remember that you need to treat the patient as a whole. And this is the patient. You need to consider other injuries. He's got multiple long bone injuries. He's got a cervical spine injury. He's got skin and soft tissue damage. But however, if you notice from the picture, I'm not sure whether you can see, he's only on a high flow nasal cannula. He's got good arterial blood gas. His ventilator settings are very, very low. And so in this case, I was hesitant to jump in and repair because he had much more other serious injuries. So it's good to step back and not jump in straight away, especially when you know in such a case where you don't have skin and soft tissue cover. The last thing you want is to put in prosthesis. So what about in malignancy? It's a totally different ballgame. You need to know whether is the tumor resectable, and it needs to be resectable with good and clear margins. Is the patient operable? The next thing. Will there be adequate pulmonary reserve? Will the chest wall dynamics or respiration be compromised? And most important, with everything that we do, is there any survival benefit, symptomatic or cosmetic? So there are many indications for chest wall resection. The most that everybody talks about is chest wall tumor. Benign and malignant literature quotes that about slightly higher preponderance to malignancy. So when you have a chest wall mass, you need to act real fast. The benign group is very heterogeneous. It can arise from anything: skin, soft tissue, muscle, bone, cartilage, lymph nodes, nerve cells, anything. And malignant, you have all your sarcomas as well. So, and then in chest wall reconstruction, we also consider osteomyelitis of the sternum, post-cardiotomy, chest trauma, like I showed you the picture just now, and also chest wall deformity. But before we jump into surgery, we need to stop. Because if the form pre-operative assessment, your MDT discussion, you cannot achieve good margin. So in sarcoma, we want at least 4 to 5 cm. If you cannot achieve that, it might not be worth doing the surgery, or you might need to refer the patient to another center who can do it. And the second thing, if you cannot restore the form, function, or reduce its pain, please try and do no harm. So in every surgery that we do, you need to have a plan. And the plan in surgery, you need to take account the anatomy, where the breast is, the male, female breast, where the bony structures are, where the scapula is, and where all the major muscle groups of the chest are. So from resection to reconstruction, what do we do? So there are many options for chest wall reconstruction. Bone reconstruction, there are many processes in the market, but it's best to use what is available at your center and what you are familiar with and trained with. Soft tissue cover, we have muscle flaps, free flaps. You can do myocutaneous flaps. You even can do omental flaps if you do not have adequate soft tissue cover. For skin, we can do skin mobilization, split skin graft, or maybe a delayed skin graft, and treat the wound with a back dressing initially. So this, I would like to introduce my professor. He's Vladimir Anikin, somebody I had the chance to work with for more than a year at Royal Brompton and Harefield. He's written this very nice 6-page article on the principles of complex chest wall reconstruction. It's a very easygoing article. This is me and him in Bali last year when we attended the Indonesian meeting. If you have time, look it up and read. It gives you a step-by-step approach. But basically, these are the processes that we use. So we have the rib fix system and also the Stratos bar. So Professor Anikin loves the Stratos bar, but in Malaysia so far we only have the rib fix for now. I think in Singapore you have more options there. So the main thing we need to consider is to improve function. Chest wall dynamics. So this is a motor vehicle accident guy, steering wheel injury. You can see the steering wheel mark just below the ribs there. He's got a failed segment. The ribs are basically broken. You can see he's in a lot of pain. There's blood coming out of the ECT tube. So we need to know, like, we need to fix this kind of patients and solve this problem. So in imaging and role, basic chest X-rays are mandatory. We need to have a CT scan contrasted, likely if you're dealing with malignancy, or high resolution CT scan, and MRI if you think soft tissue is involved. This is a famous quote that was taught to us when we were in medical school, that the eyes cannot see what the mind doesn't know. If you cannot see, get a scan. In the scan, make sure you can read the scan. If not, get your colleagues to read it for you. So this is an example of a chest radiograph of one of my patients. You can see masses in the left hemithorax. So it's a mass intrathoracic, extrathoracic. It's soft tissue, bony mass, foreign body. We'll come back to that. This is another patient of mine, a very young girl. The parents brought her in, I think she's about 6, and she has a small swelling over the right chest area here. You can see in the lateral view. And then when you do an X-ray, you have this. And she has basically a bifid rib here, where the sternal head of the 5th rib has splayed into 2 separate heads. So with time, these 2 heads will continue to grow. This will become more and more prominent, and the bottom ribs actually will push the lower ribs apart. So which will give you a very big gap and deformity. So we need to plan when is surgery. She is growing. It's right near the breast. Besides now cosmesis, it's best to defer surgery till she's a bit more older. So we look at a bit of case discussion. The first case is a patient with a chest wall sarcoma, a very young gentleman. And this mass tumor, you could actually see it growing in the wall. So this is a CT scan. You can see here this huge mass on the left, all right? And you can see it's going just above near the sternum, involving a bit of rib. Pec major could be involved. But what was more pressing for us was the involvement of the shoulder. So this is an MRI of the same mass that you can see. And it's clear that it's involved a bit of the deltoid muscles, but however, the humerus and the teeth muscles are all quite good. All right, so we were quite certain we could get good margins for this tumor. So the principles were pre-op imaging. We did a HP, it came back as sarcoma. And the resection plan, we got the plastic team involved. We did involve the orthopedic team as well because it did involve the left shoulder. And we had a plan B. If they couldn't have extended margins, what were we going to do? And we also thought of multiple flaps if a rotational lat dorsal was not enough. So this is a short video of the patient. You can see the mass here on the left chest. This is a lateral view. It looks really big. And it goes right up to just in front of all your muscles. So we resected everything, including the anterior deltoid. We put 3 plates. This is part of the sternum still there. A rotational lat dorsal flap with SSG cover. And over time, the wound healed like this, and all margins were negative, which was very good for him. This is the scar at the back of the lat dorsal. Okay. So for the second case, I'm going to talk a little bit of what my professor's forte is: unstable sternal tumors. All right. So what do we do? So if you look at this video here, this is a patient post-cardiotomy with a very obvious unstable sternum. He is breathing on room air, and you can see basically the chest just swinging. And if you take a lateral view, you can actually see that it dips, and it even dips. The left and right hemisternums are not in contact at all. So at this juncture, what do you think it is? The skin is intact, there's no pus, but is it just a wire failure, a closure failure? Is the sternum in segments? Is there any sternum left? Has osteomyelitis set in already? And is there any sternal bone left? So we need to answer all this before we actually embark on trying to fix this patient's problem. So imaging, again, chest X-ray, AP lateral, a CT scan with bone recon will greatly help. So aspects to consider: skin cover again, muscle cover. So in this situation, we like to use the bilateral pectoral major advancement flap. Sometimes you actually disconnect the pec major from the humeral head so we get more coverage. And the biggest problem is how to fill the sternal gap with bone graft, bone cement, omentoplasty, and after that, how do we stabilize the repair? So this is this gentleman's 3D bone scan. As you can see, there's hardly any sternum left. The sternum is in bits. The manubrium itself is gone. There's just nothing there in the center. So the principles of sternal reconstruction: stabilization. We need to remove all foreign body, necrotic, and unhealthy tissue, stimulate bone regeneration, fill in the gap, improve blood supply. Because currently this bone is avascular. So these are the pictures. I'll just show you a quick video as time is basically pressing. So this is us. We've opened up the same incision. We are raising up the flap. All right. We are removing whatever plates or screws that we initially put, while a secondary team has already harvested the omentum with the very good pedicle, blood supply pedicle. All right. We excise the middle part of the bone, which is unhealthy. All right. And the way we do it is we just knock. If it doesn't sound like bone, it's not bone, it needs to be removed. We make a hole in the diaphragm. This is my professor here doing it. We try and split the omentum if you can. Put one at the base, right on top of our resection. We attach it with just interrupted sutures to the edges. And then later we put plates. So he's a very big fan of Stratos bar because he thinks it's easier to remove as well. There are pros and cons to this system. And then once it's fixed, we put the omental flap back on top. So the omental flap serves as your blood supply to your bone graft site and to promote healing in this area. All right. And we loosely just tack it down to the muscle there. And then once that's all done, we mobilize, we put in Redivac drains. Seroma is a big problem in all the dissections. So that you see is the pec major muscles advancement, which you can close. And we close the skin primarily after that. Okay. Another case where we had TB of the sternum, where we excised everything and we didn't want to put prosthesis inside. So we used bone cement meshed between two meshes, and this is loosely attached to your periphery. Bone cement can be used, but however, it's very heavy. Patients are not very comfortable with it. And if it tends to crack and break if you actually meet into an accident or somebody knocks into it. So there are pros and cons for using bone cement. The third case discussion is a lady with an ulcerated fungating mass. General surgeon referred to us, but didn't wait for us, so they immediately did a mastectomy because of the fungating mass. However, the HP came back and the deep margins were involved. And then they referred inpatient to us. So this is her CT scan before the mastectomy. You can see she has a huge mass on the left breast coming up, right? That's the mass. You can see a pec major muscle which has blood supply coming out, highly vascular. And you can look that the tumor actually is in contact with the pec major. So the pec major is likely involved. And then we're not sure whether the intercostalus is just sitting right there. Even in front of the sternum, there's a lot of edema. So, and then you can see it's fungating the air pocket levels in the tumor as well. Right? So what are the principles of a redo? So what I was taught, you need to have ensure adequate margin, and it's not fair for the patient to put her through a third surgery. So you're already going in a second time, make sure the second time you do a very good job. Get an up-to-date imaging. If the scans are more than a month, we don't accept, repeat the CTs, repeat what, get plastic team and get a family conference for the family to actually understand what we're trying to do. So this is actually how big the wound was. So the issue we had with this patient was the pathologist couldn't tell us which aspect of the specimen the deep margins were involved because the pec major was involved. So we ended up removing the ribs. We removed the entire sternum. We used the mesh plate for the sternum. We placed it with ribs. Okay. And this is a short video of the entire. You can see how big the defect is. That's the plate and the mesh. And then we again took a rotational LG flap for her. Her flap was actually very thin, but we managed to do with a little bit of an advancement pec major flap as well assisting. And after a while, she recovered and her margins as well were clear, which is good news for her. So in this case 4 is the X-ray I initially showed you here. And then if you look at the CT scan, so this is a bony mass, but it's a bony mass involving just a single rib here. This case I actually discussed with Dr. Harish, if he remembers, maybe a year and a plus year ago, about what would my options be in reconstruction, because it's a single rib. And the gap between the spaces, if you can notice here at the back, where's your first, second, third, then this whole thing is the mass, and then the next rib is low down here. So we realized that the longest plate available is 30 cm. The resected specimen is 25 cm, and if you took the circumference is more than 30 cm. So you couldn't use a single plate. So options were to use 2 plates and fix it in between with wires, or fix a vertical plate in between to hold the 2 plates, or just fix vertically among the upper and lower ribs, or an oblique fixation. So we decided to go with an oblique fixation here, as you can see. As the ribs are angled down, this are basically an oblique rather than a vertical, which we thought was not very physiological. Our patient recovered well and not much complaints. So as to end all this, my take-home message is chest resection and reconstruction requires a team. MDT approach allows multiple options to be discussed pre-operatively. Always have options and be prepared with options. There's no point only discussing options during the MDT, and in theater you do not have everything. So it's good to have everything ready. Importance of up-to-date and recent scans. Post-operative plan for rehabilitation, wound care, repeat scans and adjuvant therapy need to be discussed pre-operatively. And if malignancy is suspected, time is of the essence. Do not wait 2 weeks, 3 weeks, 1 month for it, because you'll actually miss the boat. With that, I thank you.
Well, amazing work, Gerald, and congratulations on all the outcomes for your patients. So I'm going to do the last talk for today, and I'm going to talk about why robotic surgery or robotic thoracic surgery. I think this is a hot topic going on right now, and I've been a uniportal vet surgeon for many years, and in the past 5 years, I've decided to take on something new, which is robotic surgery. So I think I'm just going to put a quick brief. I'm not trying to convince anybody on why it's better or why it's worse, but I just want to get the audience to understand that probably this is the next phase of thoracic surgery and why we should go there. So, robot, basically, I looked it up online. Before this, my disclaimer is yes, I'm receiving an honorarium from Easy Search, and also I've got some slides from some online talks also, and I mashed it all up to put it all together. So, a noun, basically, a robot is a noun. It's a machine resembling a human being and able to replicate certain human movements and functions. So I always want to know where that word actually came from. So the word robot basically came from a Czech director who actually started basically a play in 1921 called Rossum's Universal Robots. And it came from the word robota, which he created himself, which meant actually forced labor. So, like any show, just like think the robots were happy to work with the humans, but eventually turned on the humans and led to the extinction of the human race. So, what does that tell us then? Basically, when you look at robots, right, it's always a spectrum of pop culture. Now, I've grown up when I was a kid, the good robots were all like R2-D2 and C-3PO. And as with time evolved, robots became like the Transformers. Some were good, some were bad. They will help us and some may go against us. And of course, we have our Terminator, which is, of course, the worst robot ever. And that led to our destruction of humankind. So going back to the archives, the first robot in surgery was actually the Puma 560, which is designed in 1985. It was actually first used for neurosurgical biopsies. And 2 years later, they used it for a laparoscopic procedure, doing a cholecystectomy. And then after that, they used it for transurethral resection. Slowly, this started to evolve very slowly in the 1990s. There's the ESOP system, which was FDA approved. And you can see the photograph over here of how the surgeon sat on the console. I think it never picked up because we probably didn't have the technology as much then as what we do today. So where the robots actually came into play was the evolution of Da Vinci. And Intuitive Medical made this robot in the 1999, the first generation. Subsequently, in 2006, they came out with the Da Vinci S. But I think where it started to really pick up was in 2009 when the SI came out and they started mass manufacturing it and sending it out throughout the world. And then, of course, most of us right now are using the Da Vinci Xi, and we've got the single port. And as of this year, they've come out with the latest robot, which is called the Da Vinci 5. Now, I think after Da Vinci's, what's that? Expired, basically, what happened is that more and more new companies now have patent expired. More and more new companies now have started producing robots. So just want to look at the world outlook on robots. So if you look, this is from Global Market Insight, and the current value of robotic surgery basically is about $6.3 billion worldwide. Now, if you look at the growth rate, what they projected is a growth rate about a compounded annual growth rate about 15.9%. So really, in about 8 years from now, the robotic market value is estimated to be about $26.8 billion. So that's almost a fourfold increase in the amount of robotic usage in medicine. Now, what I also went and did was I said Google Analytics are quite brilliant. And I did this search on keyword searches, and I compared robotic surgery search to minimally invasive surgery search. And if you look, this topic was actually focused around Singapore at that time. And one of the key comparison words when they looked at it, like Singapore and Malaysia were actually quite comparison when patients actually looked up types of surgery versus robotic versus minimally invasive surgery. And it was a big search outlook. And if you look at the worldwide searches, basically, of people actually looking for robotic surgery, of course, US being number one, Singapore being number two, actually, in the content of searching for robotic surgery. India, Australia, and Ireland are the top 5 searches in the world for robotic surgery. I always like to show this last one. A lot of times surgeons always tell me that, oh, robotic surgery may not be the thing, and I can do surgery better or worse or something like that. But I lost my screen. Sorry. Where did it go? There we go. But what I want to always show is what the global trend is. Now, if you look at the share price of intuitive surgery in this was October last year, it was valued at 266 US dollars. This snapshot was taken on the 1st of July. It's now at 436 US dollars. Now, if you bought, I'm sure all of you all would have bought a car maybe 20 years ago. And if you bought a car in 2004, and you paid 50,000 US dollars for it. Instead, if you invested $2 US on a stock, today that stock would have gone up by about 21,000% in amount. So you'd be very, very rich. So in the end, basically, is that we as surgeons must always understand that technology always evolves and we have to go with the time. And so with that, the world is actually also believing in it. And that, or I always tell people, you just reflect it by the stock market amount of the company. So that's what we look at. So with that, you can see because of that, there are many, many now robotic companies coming out there and designing new and new robots. You've got the Hinotori, you've got the Cambridge device, you've got the Medtronic robot. I think J&J's got a lot of robots. Even in China, there are a lot of new robots that are coming out right now. So as surgeons, as the world is moving, we're going to find out why the robot is actually probably going to be a thing of the future, or it's already there today. So simple case scenario, this is what we all probably encounter. You got a 60-year-old female, newly diagnosed to have adenocarcinoma. What would you do? At the end of the day, lung cancer surgery, it's the same operation. We're going to do a lobectomy or segmentectomy, and we're going to take out the lymph nodes. So what are our options? We can go back to the old school way where we do an open thoracotomy for the patient. We can do it via a VATS, minimally invasive approach, or we can do it via a robotic approach. So you can see here with open thoracotomy, we all know the outcomes of open thoracotomy is very big cuts, longer hospital stay, risk of infection is higher, pain being a big factor over there. Then you've got VATS surgery. You can do it by uniportal or multiportal VATS. And of course, now you have the robotic approach. So what are the advantages of that? So we all know this, it's less pain, shorter hospital stay, reduce infection risk, decrease psychological insult, on the physiological insult on the patient. They get a better post-op immune function, and of course, also better cosmetics because it's smaller cuts. What are the disadvantages of VATS though? Now, this is where I've transitioned and moved to more, I still do VATS, I still do robotic, but I just want to tell you all the slight disadvantages because every good thing is always a negative to it. And the first thing is with VATS right now, everything is, our visualization is 2D. You have decreased dexterity, so what we call non-wristed movements because our instruments are straight or slightly curved, but it's only opening up left and right and up and down. Okay, we lose our natural hand-eye coordination because if we want to go left, we have to move our hand right and vice versa. There's decreased sense of touch, which is the same with the robot also. And of course, we, as all surgeons, and something we can't stop is our age. And as we get older, our back starts to hurt. You can't stand up for a longer time. And some surgeons actually have a little bit of psychological or physiological tremors, and that can be amplified with the VATS instruments. So what is robotic surgery? Every time my patient comes, they always think that the robot is going to do the operation. So I tell them, no, there's nothing automated about robotic surgery. Is the surgeon is actually still going to do the operation. But the difference is that what we're doing actually in robotic surgery is that we've moved from analog to digital. So we are digitalizing surgery. That's what we're actually doing right now. I took a photo of this. These are what surgical instruments looked 150 to almost 200 years ago. And if you look at the type of instruments that they were using, it's actually very similar to what actually we've been using currently right now. So there are actually no real major advances in our thoracoscopic instruments. They all have the shaft, they all have the handles, they all have the hinges in the side. Difference with robotic surgery basically is that they actually have improved it in such a way that it starts to mimic your hand movements. And what we want to do is we want to operate like we're operating with our fingers and ability to have increased dexterity. And that comes to the point of this slide where we can see that with robotic arms or the instruments that we use, it actually follows our hand movements, and we have a range of about 270-degree rotation, and also the dexterity goes up by about more than 50%. So this slide was borrowed by one of the presentation online, and it was very nice how he presented. And this is kind of the ape to man kind of evolution. I always like to bring up the music industry because they always, everything else besides medicine goes very fast. So when you look at this, you can say when the vinyl first came out and then people started producing tapes, the vinyl record people were saying, oh, vinyls are much clearer, it's much better. And then the CDs came out, the tape people always said, oh, tapes are better and CDs are bad. And then when digital stuff came out, there was Napster, there was iTunes, now we have Spotify. They always said, oh, CD is still much clearer. But actually, right now, with digitalization, music is so clear with digital audio nowadays. And so the same concept went. And I remember when I was first became a doctor 21 years ago, everyone was still doing open surgery. And at that time, when VETS was coming out, a lot of thoracic surgeons were saying, oh, you cannot do any dissection. You can just do simple pleural biopsies or lymph node biopsies with VETS. And the open surgeons were saying open is much better outcomes. And then eventually now the world has moved to VETS, and VETS surgeons are saying VETS is the best. And it's unfortunate that many of the VETS surgeons today are now saying, oh, robotic is, the same surgeons that were actually fighting for improvement in VETS now are saying that, oh, I can do VETS surgery as good, and therefore robot is not very good. But actually what we need to think about right over here is that it's not about whether robot is good or VETS is good. It's about what is next. And I like to put these two photographs of the aeroplanes because if the Wright brothers were flying this old aircraft like this and they said, we've already taken off to the sky and nothing can be better than this, we would not have evolved to the F-35 and what it is today. And so we must always keep thinking, what's next? What can we do better? And here, so this comes to the point where as people would design, this video was more than, I think 12 years old. When the robot first came out, they said, okay, what's next? Shall we go to, and shall we do single port robot? So engineers came into play, and they came out with this single port robot. Of course, this at that time was a prototype. And you can see how the hands are moving, the dexterity is improving, but it wasn't ready yet then. But after some time in 2019, came out the single port Da Vinci robot. And then with that, Shuri, which is the latest Chinese robot, I see they're coming out with also a single port robot. So evolution, technology is moving that fast. What else can we do? We always talked about, I love playing video games. And then whenever I drive my in a Formula One race car or with my steering wheel, I go off track and I can feel all this haptic feedback and movements. And then with VR goggles right now, you can actually feel certain things. If you play tennis, you can actually feel how hard the ball is being hit or how soft the ball is being hit. And so we said, okay, what should we do with haptic feedback for robotic arms? Against this video was actually taken a few years ago when they were just trying out haptic technology for the robotic arms and how we can actually improve our touch sense when we're doing surgery. And right now with the new Da Vinci 5, they've done it. They've come up with haptic feedback for the robotic arms, and you can actually tell how hard you're poking, how hard you're pulling, and it gives you even a measurement in numbers of how much strain you're putting on the tissue here. So this is evolution, and this is surgical evolution and why we're going that direction. At the same time, visualization is so important. Like I mentioned to you, firstly, being a surgeon and sitting down and operating, I think is one of the best things ever. Of course, I get a bit fatter doing it this way, but my back, my posture, everything has improved. My arm movements, everything else is more coordinated now. I'm more relaxed. I'm more comfortable. And with these latest technologies and our vision that's better, the latest Da Vinci 5 has 4 times better pixelation. It has got more realistic 3D images. We've got better depth perception. And of course, the clarity and the color behind it is actually amazing. So this is why we are moving on to newer and newer technologies. What I like the best about the robot is the training part. So you can see here, there are 2 consoles here. I'm sitting on one console here, and my other colleague is sitting the other console, and we're doing a case together. So when I was doing VETS that time, firstly, someone's holding the camera's moving left and right. And then when I want my assistant or my junior to take over and start to do a little bit of the operation, I have to step aside and move aside. But when you have dual console system in robot, the training becomes great. So as I'm doing all the dissection, you can see here, there's a button there called Give All. I can just hit the button and say, okay, your turn. You just take over the operation right now. And he's on the other console. He takes over. and he starts the dissection. If I don't like it, there's a button called take all back. I just take all the instruments back, and he just goes back to observation. So training, real-time training becomes immensely improved. All right. What about other things? You know, when you get on you see all these documentaries of fighter pilots flying the plane, they have all these heart rate monitors attached to them. They have all this latest technology to see whether they took off too fast, took off too slow, turned the plane left, turned the plane right, the wrong way. That's where surgery is moving to right now. We can get beautiful insight with all this AI technology right now. Tell us how to improve our surgery, where our shortfalls are. We can understand our surgical performance better, and we can review all these steps. And next time when we go and sit in the console, the robot may even tell us, okay, you know what, you did this the other way. To speed up your process, you can take these other few steps here. And so that way we actually can learn to become better surgeons. It also is a really much better training tool. So now when it comes to data, you know, if you Google and you type robotic better than VETS, then you have a lot of data on that. If you want to have VETS a lot better than robot, you'll have a lot of data on that. So that's a debate at the end of the day, what you want. But we always come down to really what it is the cost, because the robot costs a lot of money to start up with. But once you start using the robot many times, you'll find out that the cost actually becomes cheaper. And this is why I pulled out this paper. So at the end, they said duration of surgery was shorter than robotic versus VETS, which of course is always debatable, depends on who's operating. And they said here that the robotic cost was higher, and the hospital makes a profit from it. And the reason for that is that many times the hospital wants to claw back the money that they bought the robot for. So say if you spend $3 million US buying the robot, the hospital will charge what they call a utilization fee for the robot. So when we started the program in a university hospital in Singapore, we actually went to management and said, look, if you're charging $3,000 to $4,000 excess cost for the robot, you're not going to get many people to use it. However, when we dropped the excess cost to $1,000 instead, more and more surgeons started taking up robot. And now they, instead of doing 5 cases a month and then the hospital makes $15,000, they're doing 30 cases a month, charging at $1,000 per case. And therefore, the hospitals start making more money, which the robot's being utilized, and they make $30,000 instead. So this is one way to do it, that actually comes down to talking to the hospital and telling them to reduce the cost of actually the utilization fee of the robot. Of course, then comes to the point of, is VETS better or robot better? Now, I actually find for mediastinal tumors, and robot was always known to be good at this, whereas we are dissecting at very small spaces. So especially in the anterior mediastinum, we do a thymectomy or anterior mediastinal tumor, having a robot is immensely, really much better here, at least from my perspective. And because you can just get into that really very small space, and because the robotic arms are small and it's agile, you can actually go and dissect and remove that whole tissue easily. This is another graph that shows, this is in 2010 to 2016, about the utilization of robotic surgery for mediastinal cases. And in the US right now, I think a good 40 to 50% of them are doing it fully by robot. Again, some random papers I pulled out. They said here that a robot probably, there's a Japanese paper that has a shorter operative time and a shorter post-operative stay. We talk about lymph node dissection here. This I can almost be certain that with robotic surgery, you can actually dissect more mediastinal lymph nodes. And being a VET surgeon doing lymph node dissection, you have to be very competent because you're dissecting around very tight, very dangerous structures like the pulmonary artery. With the robot, I think even your registrar or your junior consultant can perform it with much ease. So in Singapore, more and more robots are taking over in the hospitals right now. They're being evaluated for patient care, for education, even sometimes to even put simple medicines onto patients' tables. So yeah, we're going about that. So robot is something that's going to be there. It's going to be there for a long time. It's going to probably be part of our medical work in the future. So I think it's important that we dive into it, and we dive into it early. So this is my first video of a robotic thymectomy. This is actually my first ever case I did. And I always choose a very, very simple case, which is a robotic thymectomy. I think is the best and easiest case to do. And you can see, being the first operation, you can see how where I'm just dissecting right above the pericardium over here. And it's very, very simple. So you're basically like operating with your fingers, you're plucking and peeling. This is opening up the mediastinal, pleura right under the sternum here. And it's just slowly picking it up and burning it. Whereas I always found thymectomy with VATS, for me at least, I found that to be always a very bit tricky and difficult. And this is the part that I'm always concerned about the innominate vein. So you can see here how I'm taking out the horn over here, and how just using two arms and you're just dissecting it very, very slowly, but you can see how the arm is so sharp and precise that I can just get right above the innominate vein and just take the thymus off very, very easily over here. The other area we're always concerned about is the inferior thymic vein. And I used to always put a clip, but actually with the robot, I just use the bipolar, I just burn it. I've never had a bleed so far doing it. So here we are just cleaning it off the pericardium, and you can see I've gone all the way to the left side of the pleura here. And one of the best things ever is that I didn't have to move the camera or change the camera or clean the camera one time at all during this operation. So if anything else that besides the arm-wristed movements and the dissection capability, I don't have to worry and be a bit upset with my cameraman or camera lady who always has to move the camera and tell them you need to look at in front or at the back. So that's the good thing about the robot. Everything is under your control and your hand movements. The next case, so what about slightly bigger tumors like an anterior mediastinal mass? Again, the largest tumor I've ever taken out was about 7 centimeters. I agree that even if it's a 7 centimeter, you have to make a bigger cut to deliver the tumor, but the dissection, it saves the patient's anatomy, and the dissection is amazing. So here's that big tumor, about 5 centimeter tumor that we're removing it. I always start from right above the phrenic nerve. And you can see I can actually control the tumor and the movements of the hand very, very easily. I have like a no-touch technique on the tumor where I just hold the pleura overlining it and just retract it over there. And we keep dissecting the tissue. And you can see here, we're just pushing on the tumor. We're not even pulling it. Just a slight tuck down so you can get a better exposure. And this is taking out one of the horns. And this is the part that I used to find it very difficult with the VATS. But with the robot, the horn dissection for me is so easy. Again, like I mentioned to you, it's like peeling it off with your fingers. So we're going deep in. This patient had a really long horn. And you see we keep on dissecting and pulling and pulling. And it's still coming out. And there we go, it's out right now. So this is the design. The nice thing about doing it with the robot is that the arms are very fine and you can actually maneuver it with your fingers. So clearing up the tissue. Lastly, this is a non-myasthenic patient, so I did need to do a complete removal of the pericardial fat also. So we just took out all the tissue over here, and we can deliver the specimen then once it out via bag. So with big tumors like this, the delivery port has to be extended, especially in a thymoma patient. You don't want to break the tumor. Then that will distort your histology at the end. So usually I always tell my assistant by the bedside, just increase the size of the cut, maybe about 1 or 2 centimeters to deliver the tumor out. And then you can see here a very clean dissection. And the last video is a robotic lobectomy. So we always do VATS lobectomy by VATS and uniportal. So the difference here is, yes, we're going to have to put more ports for the patient, but the cuts are actually very, very small. And I honestly haven't seen any outcomes when it comes to the pain, any difference. Sometimes I do a uniportal VATS and this patient is painless. And sometimes I do uniportal VATS and patient is screaming in pain. So really it's no difference. But this is the best part about robotic lobectomy, the lymph node dissection here. And so you can see here, this is a highlight lymph node that we're taking it right off the pulmonary artery. And you can see I can get up really, really close and without any problems at all. And I always struggled with VATS in this way sometimes, taking it off the PA. And here we go, we're separating the fissure. So easy search staplers, this video is a bit old. almost about a year and a half or 2 years old. So we didn't have those staplers in Singapore then. For my robotic case, I don't use the robotic staplers, number one, because of the cost. Number two, I noticed most of my Asian patients are very small-chested inside, so I always struggle with the robotic stapler. So I get my assistant to fire the staplers from the working port over here. So you can see here we're doing that. Again, getting around the lingular branch right now. Snipping off the lingular PA branch. Again, every movement here, every retraction is all done by myself. Camera angulation, all done myself. So only the stapling part where, because I use the external staplers, I get my assistant to just pass the stapler through, which is actually quite straightforward. I'm very fortunate that my colleague who assists me is a very senior colleague, so I have no issue with the staplers. But even so, then if your assistant is a vet-trained surgeon, these stapling shouldn't be a problem at all. It's very, very fast. So once you get around the blood vessels, you just fire away. That's the truncus branch. So once that is done, for this particular case, I didn't take the vein separately. I decided I got enough margins, and I took the whole bronchus together with the vein as en bloc. As en bloc, sorry. So there we go. The lobe's done. And we deliver it through the bag. So at the end, my last slide is basically this video. It shows the comparison of Formula One pit stops. This is it. The bottom one is a Red Bull pit stop in 2019. And in 1981, the video above is the pit stop for a Formula One car in 1981. So just look at the time difference. The down one is 2 seconds, in, out, and there goes the driver. But you can see in 1981, they took a really long time to change the tires, to check the car. It's almost like 29, 30 seconds at pit stop then. And if they're still doing it. Okay, and off goes that driver. So you can see from the presentation today, all our speakers basically shows evolution in thoracic surgery, from dissecting 4L lymph nodes by vets, where it probably couldn't be done before, from our esophageal work, how they're doing it minimally invasive right now, and from chest wall reconstruction with plates and everything. So medicine's always evolving, and we always have to keep up to date, and we always must try new things. If not, we will never evolve. So with that, I'd like to thank you and thank Easy Search for this organizing this webinar.
Thank you.
Great. So I guess we have a few minutes. Maybe we can do a Q&A. I wonder if the audience can actually ask some questions. But I guess I'll kick it off with Dr. Nara. Dr. Nara, thanks for showing us the 4L lymph node dissection. Now, from your opinion perspective, how experienced do you actually have to be to get in there to that 4L area? Because a lot of times there's a lot of dissection that you have to retract quite well. You have to know your anatomy quite well. The recurrent laryngeal nerve is sitting right there. The vagus nerve is sitting right there. And a lot of times, once we dissect that area and say if it's negative, that's great for the patient. And but unfortunately, sometimes when we dissect, there's a lot of traction and stuff. They can get recurrent laryngeal nerve injury. What's your advice to surgeons attempting this dissection?
Well, that's one of the reasons why most of us shy away from dissecting 4L. But again, we have to look at on the other perspective of why 4L is very important is because of the involvement of 4L in the metastasis of the tumor. So you have about, based on the data, anywhere between 17 to 20% of 4L lymph nodes actually are involved in adenocarcinoma of lung. And if we don't dissect the 4L just because it's difficult, then we are actually missing about 1/5 of metastatic lymph node. How to minimize the damage is just like how we look at any other surgical training. We need to be very alert about the anatomy, the borders of the 4L region, and again, observing surgeries again and again, looking at the experts doing the surgery, doing it with assistance from the experts, and then using cadavers to explore the area. But all these so-called cadaveric dissections, simulations will not give you the impact of the complications that you may encounter, especially in areas like 4L. So the only thing is to be alert about the anatomy and judicious use of energy device. So as alert as we are about the anatomy, if we are not careful with the energy device that we use, then it will injure the structures inadvertently. In this 4L area, if you have a robot to dissect this area, it will be amazing because as you explained earlier, the dexterity of the arm, the way we can retract, and especially with the Da Vinci 5, it'll be wonderful to have the tactile feedback from the pulmonary artery, how much pressure you can exert, and probably we can incorporate intraoperative nerve monitoring to prevent injury to the recurrent laryngeal nerve. So
Yeah,
these
amazing.
are the steps we can use to minimize the damage to the structures.
Yeah, so that's actually a really good point. I think one of the good things that with the robot that I could do is that the retraction, I could put the fourth arm in and just push and it will stay. So there's no movement. And my assistant, which is just standing there, my camera doesn't have to move anymore. And I'm very focused there with the robot. So I actually can get
True.
the 4L node easily, or easier, not easily, but easier that way.
True.
Great. Dr. Malgoro Zata, amazing work with esophageal surgery. The unfortunate thing in Singapore is that, well, I don't do esophageal work. It's done by the upper GI surgeons in Singapore here. However, I do get involved sometimes when there's an anastomotic leak or something, and there's a lot of adhesions to the lung. They need to take down that area again and repair that area. Now, I want to ask you a question with regards to an anastomotic leak. If there is an anastomotic leak, do you all actually use the endovac dressing
Yes.
to do that? And what are your
Yes,
outcomes
yes.
of that?
So we use the VAC dressing, and we got very well results with it. It depends how big is the leakage, but for the small fistula, for not very intense leakage, the VAC works really good.
Amazing. And so when would you intervene then? How long would you keep the patient on the VAC for? And when would you intervene to repair or defunction that area that's leaking?
So the healing the time of the healing is different in each patient. The patient with the lung cancer, with the esophageal cancer, sometimes they have problems with the nutrition, with the food swallowing, so the quality of the tissue is not that great, and most of them are after chemo and radiotherapy. So those factors make the healing worse than the other patients, in the other patients. So you never know how long does it take to heal the fistula, to stop the leakage, but well, 2 weeks, sometimes longer.
Okay.
Each
So
each case is the individual. It depends. When is the micro fistula, you can keep the patient on the VAC and just give him the the nutrition through the microionostomy or IV. But it depends how it goes. You can check it with the endoscope, and you can see if it's better or it's worse. So.
when would you actually intervene with these patients then? Like what's your criteria to intervene if the endovac's not working?
So like stop the VAC treatment?
Yes.
So when we check it endoscopically and it looks like it's healed, Then we can do also the CT of the chest to see if there is how it healed. And then we do the test with the contrast swallowing, with the contrast, and if there is no leakage, then means that's already healed.
Sorry, my question was, when would you intervene if you know the vac is not working? So you've done your scope and there's still a hole, and the hole is
Okay,
persistent.
so when there
Yeah.
is still well, it's not easy to say, but when it's not working, then you can go with the stent.
Okay.
You can insert the stent, then and if there are any problems, then the surgery. But usually the stent will cover the fistula.
Okay, thank you.
Thank
Dr.
you.
Jared, well done with your chest wall resection, and I guess in Kota Baru and in Terengganu, you probably have a lot of these cases coming up to you. Has there been any operation that you did and you placed the plates and these plates end up dislodging? And how would you intervene them if they do?
Yeah, so thanks, Arish. Yeah. So I think with any prosthesis we use, we need to follow up. So with, I tend to put more screws, especially when the bone, when you screw the screws in, when you fix the place, you can have a sense of how strong that bone is. And if I'm not very confident with how much that screw holds, I depth gauge again, measure again, make sure I got the correct screw size, and I put additional screws. There are times where the plates have got dislodged. And for me, if it's dislodged, even though it's asymptomatic, you have to take it out. Because if they do not cause problems now, they will cause problems in the future. And if the fellow meets with another motor vehicle accident, most likely that plate is now a foreign body that will cause more trauma than anything else. So I will always usually take it out.
Okay, so especially with chest wall recon, when there's a dislodgement, because there's a lot of flat muscle there and stuff. So to get in there is actually quite a tricky thing. Do you go back in and make a big incision again, or do you just try to localize where there is dislodging?
So like, we will do a repeat scan, and then if I really cannot feel where the broken plate is or where my screws are, I get my radiology colleagues to help. And then we make just a small incision and we just take off the plate. We do not reopen back the entire well-filled wound.
Okay. And have you stopped using bone cement?
Yes.
Yeah. Okay.
Bone cement is very good, very cheap, but patients usually complain after a while. One thing is the weight. Bone cement is heavy. It's very heavy. And then they have like some sort of allergic reaction. The patient just doesn't feel nice. It's very easy, very cheap, but no. And then once bone cement cracks, removing it is a nightmare because you have pieces just everywhere. No matter how much you wash, there's still fragments of bone chips, bone cement everywhere. So I do not use bone cement. The case which I showed you, that CT scan, that's actually TB of the sternum. And the reason we opted for that was because we were unsure of our margin. So we did put bone cement, bilateral advancement packed medial flap. Once he completed his treatment for about 9 months to nearly a year, we waited. Everything negative, he was well, putting on weight. So we actually measured that he was putting on weight. Then we went in, we actually took out that bone cement and we actually plated everything. And then because we initially was just advancement packed medial flaps, the second one was myocutaneous flaps. So it was quite a straightforward redo surgery for them.
Okay, great. Thank you. How about the our speakers? Are there any questions you want to ask to the other speakers over here? Nara, is there anything?
Yeah, can I just add on to the plate dislodgement question that you highlighted? I agree with Gerard about the dexterity of the bone, but in addition, what I do nowadays is that I add on a circlage to the application of the screw to prevent the dislodgement. Because over the after months or years of plating, the screws may dislodge, but the plate will be already fibrosed on it. And if you have a circlage around the plate, it will further assure that you won't have dislodgement of the plate. If the screws dislodge, you can just leave it, let it be. The patients most of the time will not complain about anything. So that could be used as a so-called insurance to prevent the dislodgement.
Right. I had a patient 3 years after the reconstruction. One of the screws dislodged, and we were following it like a mouse, running all over the chest over a span of 4 months or 5 months. And eventually, we
Yeah.
were actually very afraid it would go back into the thoracic cavity. And so we end up just localizing it with ultrasound and just,
Oh,
yeah. But yeah, I think what we have to be, for me at least, I'm concerned is because the screws are very, very loose. We don't know where these guys are literally like breast mouses. It can, sorry, like a foreign body mouses where it just runs around sometimes. And you always think that the area is fibrous down, but it actually doesn't. So just be careful over there.
I have a question for Dr. Waltz about the esophageal surgery. Is that okay?
Yeah, go for
Yes,
it.
of course.
Yeah, okay. Do you routinely use feeding jejunostomy for all your esophagectomies? Or is
Yes.
so all the esophagectomies you routinely apply feeding J's?
Yes, we do.
All right. And
Yes.
because there are some studies that advocates usage of trans-anastomotic tubes or nasoduodenal tubes to feed. And perhaps do you have any experience using those without the feeding
No, we
jejunostomy?
don't. We only, for each case, we use jejunostomy. We don't have experience with those tubes at
All
our
right.
department.
And one more question is in terms of I noticed you got about 12% and above anastomotic leaks.
Yes.
Is there any of these patients ended up with a colonic transposition? And how many of them that you need to do?
As far as I remember, in these minimally invasive procedures, there was no such problems. We were able to treat it with endovac and with stents, and it was not that severe.
All right, excellent. Thank you.
Thank you.
Great,
Alex,
Gerard.
one-
Go for it. Yeah.
In all your years of robotic surgery, have you ever converted?
Oh, yes. In fact, I just converted a case not too long ago where we dissected the whole upper lobe out. Everything was good. And it was a TB patient. And so there's a lot of lymph nodes, a lot of fibrosis around the bronchus. And what I didn't see was actually there was another branch of the truncus artery going behind. So I put the stapler there and I fired it, and the whole thing burst open. So yes, I had to convert. The good thing is the moment it burst open, I just took the robotic arm, I took the lung and just pushed it there. And then it had control, and then I took my time to scrub up and open up. So I didn't have that thing. I have opened up for severe adhesions before because I felt it would take me too long to even dissect all around. I've done that. But other than that, most of the time right now, I think we're quite good. I used to be in University Hospital where we started the robotic program. Now all our junior consultants, I think almost 50% of their work for lobectomies are by robot. And I can almost guarantee you 90% of the work for mediastinal disease is robot. They in fact don't know how to do VATS mediastinal anymore because it's a real, to me, it's a game changer for everybody. If you get and you sit down and you start doing it, you probably won't go back to VATS. It's much faster, I feel, because your dissection can be better.
So just to explore further on the part where you fired the stapler in the bronchus and then just burst open, right? So you must have got a very good assistant at the bedside with the patient to hold the suction and all that.
Yeah. So because, like I said, the moment it opened up, the robotic arm, my forearm, comes down, and because the lung was still there, grab and just press. So once the robotic arm press and I take my head off the console, the arm doesn't move, it just stays there.
Yeah.
So while I scrub, my assistant's already opening up the patient by the bedside.
Okay. So in that sense that you must have a competent thoracic surgeon at the bedside.
To me, yes, especially if you're starting off your program. Yep.
Okay. Yep.
To me, that's very, very, very important. I think whatever we do, we always have a colleague or even a senior registrar with you, who can actually open up straight away. I think that's the best thing. I'm very fortunate. I have a very senior colleague, Dr. Anis, who I work with all the time. So yes, I'm very fortunate there. And even in NUH, where I was, always had a senior registrar there, or even a junior consultant there who can actually repair the problem if anything needs to be. All right, is there any more questions for the floor? From the floor, sorry. Great. I guess if not, I'd really like to thank EasySearch again for organizing this webinar. I really appreciate this. I hope the audience had a good learning opportunity today. And I'd like to thank all the speakers again for attending and spending 2 hours of your time here. And with that, I guess we'd like to conclude today's session. Thank you,
Thank you.
everybody.
Thank you.
Thank you. Thank you.
Thank you.